The seminar has been endorsed for 1 GR CPD point. I'm very pleased to introduce our speakers for today, Professor Anthony Maeder and Professor Trish Williams from Flinders University. Anthony and Trish are both professors of digital health systems at Flinders University and co-directors of the Flinders Digital Health Research Centre. Both have scientific academic backgrounds and have been involved with numerous areas of health informatics and software development. Prior to their move to Flinders, they held appointments at Western Sydney University and Edith Cowan University, respectively. So today they'll be telling us more about the first 4 years of their work at Flinders Digital Health Research Centre, which was launched in July 2016. Thanks, Anthony. Trish.
Thank you. Well, let me just say a few words of preamble and then we'll start showing some slides. I think the purpose of today is almost to present our centre as a case study because having been operating for 4 years, we're probably at a fairly stable state of existence, and that probably means we're going to continue doing what we do now for some time. So I'm going to share my screen and go into slide mode. And talk about these first 4 years of our existence. And Trish and I will just tag team through the presentation, presenting different parts of it. Is that okay? Can everyone see the slides now? Okay. So I'm going to talk briefly about how we came to be a centre, and then we're going to walk through 4 different project areas that we're active in, give you a flavour for the diversity of our work, and then just end with some future looking statements. So most of you will, I hope, know about the National Digital Health Strategy, which the Digital Health Agency launched in 2017. So our existence is kind of contemporaneous with the agency. In fact, our birthdays are only a week apart. We were started in July 2016, like the agency. And really the existence of our centre has to thank the push for medical records and other factors in digital health that the agency was set up to promote. So the South Australian government had decided that they needed to get into the digital health space, and we're the result. So our centre was set up, as most centres at Flinders are, for 5 years initially, and it was jointly funded by government, Cisco and Flinders University. And it was set up as a medium-sized centre with a $1 to $2 million annual research budget. The hallmark aspect of the centre is its focus on industry. The state government was very emphatic that we should be sweeping local industry, particularly the IT industry, under our wing, and the involvement of Cisco, which hadn't previously been in a major investment in this state from the start of the centre, was very beneficial for getting that to happen. A second characteristic of the centre was we were set up to operate in the new Tonsley Innovation Precinct. So Tonsley is where the old Mitsubishi Chrysler factory used to be in Adelaide, and it's conveniently close to Flinders University main campus. So you can walk between the campuses in less than half an hour, and it's only about a 20-minute train ride to the city, so it's very well placed. And at this precinct, we have a number of other IT and health industry operators. Plus we have the Medical Device Research Institute, which has been going for many years at Flinders. And we have a number of other groups who are using similar co-design living laboratory methods that we're going to mention a little later. And then the last expectation in setting up the centre was to have cooperation with other research groups in South Australia. So we have numerous groups at Flinders, of course. There's the South Australian Health and Medical Research Institute. SARA and Data 61 have presence here. SA Health runs research activities, and the local universities have a number of groups in areas of interest to us. So it seemed like a very good ecosystem, and that is frankly what attracted both myself and Trish to come here from our respective other states. So this is what we've ended up with after the 4 years. We've got 17 very active academic members, and in keeping with our multidisciplinary ethos, they come from several different colleges in the university. And we've also been fortunate enough to get a a number of postdoc positions funded, both generic positions for example, we have one postdoc who's a qualitative methods expert, and some which are project specific. So when we have a 2 or 3 year project, we generally appoint a postdoc and have some leakage into other centre activities by that person. And particularly our postdocs are strong in the data and software side, more so than in the health side. And then we built up PhD numbers to 18. Well, that includes a few completions, I guess, but that's also quite a steady state, I think, for the centre. So let me talk briefly about my position. So the centre is run by co-directors because there are 2 endowed chairs. Mine is endowed by the Premier's Department in South Australia, and they have this scheme to create new chairs to try and grow strategic areas. It's a bit like the Canada Chairs scheme, if you're familiar with that. And in their case, as I've just said before, they're very keen on the industry connection and wanting to grow an industry sector that up to now has had mostly small to medium enterprise involvement in the state. So the model of this is that the university pays my salary and the fellowship provides the funds for resources. And I am able to spend those on hiring people, buying equipment, setting up postdoc and PhD positions. And we've done all of the above. And then we were going to try and leverage initially other state level activities in the industry sector, besides just the IT industry. So that's the medical device industry, which is quite vibrant in the state, and our Department of Trade and Industry, which has been trying to catalyse a kind of cluster of health and medical industries. So I'm now going to swap chairs and let Trish talk about her position, which is rather different from mine.
It's like musical chairs.
Musical directors.
So I'm the Cisco chair at Flinders, and that is a position that is funded between Cisco Systems Australia and the university. And they wanted to have a presence in digital health, but also were looking for cybersecurity expertise, of which I have both. So they employed me to do that position. And what happens is it's a really good relationship where both the university benefits from it as well as industry themselves benefit from it. So it is a real true collaboration, and most of the projects that I will do with Cisco have some practical translatable results, and particularly things that can be scalable. So, you know, the position doesn't actually work for Cisco, and the outputs are not necessarily just focused for Cisco. They're very infrastructure and technology based, and therefore could be used by any sorts of industry. The other thing that it provides is leadership in the area, both to support industry contacts, but also the connections that, as you might expect, both Ant and I have in the wider community, both in digital health, both nationally and internationally. So it's been a very good relationship for Flinders. And within the centre, we decided to have 4 central themes for which to build the research. And the first one of those, or the overarching theme altogether, is about digital health enabling health smart living. Digital health really becomes a service to whatever application area you put it to. And so using that technology to improve health really means that it's both looking at how you promote wellness and health, as well as looking at what you do when you're faced with ill health. So our 4 focus areas were ageing, wellness, we have a clinical focus area, and technology, because we felt that this covered the sorts of things that both the state government and Cisco might want, but more importantly, they were areas where there is quite a breadth of application that could be done in digital health. And also there's we have quite a bit of background in some of these areas anyway. The university itself has many contacts and research that's around assistive technologies, and the members of the research centre themselves bring a lot of that expertise with them as well. Wellness was an obvious one for us because we're looking to try and influence behaviour change, but that is in many different ways, including mental well-being. And then we have an area that we call clinical because it relates to any sort of apps, data analysis, and anything that we can include that looks at, for instance, clinical workflow integration with digital technologies. And then we have one that we have just called technology, which is where a lot of the fundamental research into things like IoT and interoperability is done. And the way that we approach this is looking at a very social ecological model about not only where does it fit with the individual, but looking more from a wider perspective to looking to the community, and how do these things start to influence the things that we do. So most projects would be able to articulate something in each of these areas. So really understanding what your impact is and what you would do within that related to the research. And we're going to talk about 4 particular projects of the many that we are doing and have done. There is a memory loss assistant, which is also renamed or is named FAME as a product, yes. And these projects that we're going to go through really encapsulate the breadth of what we do, but also looking at the multidisciplinary nature of all of those projects. And it has been a benefit to us being cross-college, but it is not as though people don't try and do multidisciplinary research, but actually being able to have that come to fruition with particular project outcomes has been, I think, one of the strengths that we've been able to provide. So we have a memory loss assistant called FAME, and the digitally enabled living, linked to health smart homes has been a very important type of focus area. And the other 2 projects we're going to talk about relate to information systems and infrastructure in a very broad sense, not just meaning networks, but looking at how you can improve things like patient experience related to the information capabilities that you need. And then some new work that we're currently doing on virtual care, which was happening anyway, but has been brought forward quite quickly, obviously, because of COVID.
Trish. So I'll talk about the first 2 projects. The Memory Loss Assistant project was funded under the Department of Aging, Community Services, Memory and Dementia targeted programs. And what we built in this project was a very simple aid de memoir to people who were just beginning to lose memory at a very early stage of declining memory. And we built this nice little tablet layout you can see on the left with a very simple screen that provided functions for making contacts through Skype with family and friends, keeping a calendar of events so that one wouldn't forget them, and then doing some brain training activities as a sort of time filler opportunity for people who were clearly keen to improve or reduce decline of their memory. So this project was our first sortie into living laboratory methods, and we visited a number of living labs in Europe as a precursor to see how it was done there. And we decided we would need a very well-informed design approach. So we used both the World Wide Web older user design principles, which cover a number of areas of sensitivity in the design of IT artifacts. And we used the living laboratory methodology by engaging very widely with different groups of stakeholders and cyclically improving through iterative refinement as we developed the project and indeed the intervention. So the idea of this iterative refinement, as I'm sure many of you know, is that it improves your ability to focus on the desired functionality of the product and to get a good human-computer interface and usability result. So we figured out from this that people's needs when their memory is beginning to be lost, focus on their situational awareness, you know, what date it is, what place are they in, what's the weather like, being able to reach personal contacts because they're feeling anxious about memory issues and potentially have other health issues too, and maintaining a daily schedule. So having things that keep them on with their daily routine and any exceptional activities. And as I say, we built a platform to do this on a simple tablet basis using off-the-shelf software. So the living laboratory approach has these 5 key areas of engagement, and you successively revisit all of them. Usual co-creation or co-design approach, using multi-methods to manage and assess what you're doing, engaging with different user groups, having strong stakeholder participation, and using real-life settings for deployment and elicitation. And we found that that was actually a very successful approach, albeit very time-consuming. So we had this very wide stakeholder ambition. In the end, we involved something like 30 different community groups to extract people that could either help us refine the concept, or that we could show the prototype to, or that we could actually do some controlled alpha and beta testing before the rollout of the trial. The trial itself had 2 phases of 3 months, and we recruited 75 subjects in each phase, so quite a large sample group, and quite an easy group to work with because they were mostly living in their own retirement home setting. They weren't under care, and these were people just out in the community. As outcomes, we were looking at whether there was any noticeable improvement or at least lack of decline in memory over the test period. We found a small improvement, and particularly we wanted to know about how they used it, how they found it useful, and so on. And those results are partially written up. We've still got a lot of material to process. And then we're trying to use the platform in other settings for perhaps people with more advanced mental situations, and building in other features like a survey tool too. The second project is in the suite of digital enabled living projects that are part of the ARC Industrial Transformation Hub that we're a member of, run out of Deakin. And we have a particular interest in conversational agents, so providing people with personalized interaction through some sort of agent-driven dialogue. And the group that we're focused on for that are brain injury patients, people who've had some trauma or damage to the brain, and it's affected their cognitive or motor situation. And after initial treatment, they have to go back and return to community living, but keep up a kind of rehab program, and particularly a coaching program to make sure that they are remaining on task. And this often involves techniques like motivational interviewing and the use of behavior management, behavior change principles based around goal setting. So to do this, we need really good user engagement. Any conversation with a person in this situation needs to know their name, needs to know their preferences about how they converse, needs to be persuasive and provide them with feedback and be supportive. So we chose a so-called embodied conversational agent where we would use a visual avatar as the main delivery of the conversation. And luckily in Adelaide, we have Clevertar, a company that has built such an avatar system, and we simply use their product. So the sorts of questions the agent must have in mind, and therefore conversations that must be generated, relate to these different aspects of behavior management theory that are listed on the left. And the sort of typical questions an agent might ask are in the middle column, you know, what do you want to do? Why do you care about this? How strongly are you focused on it? And so on. And then the answers can be categorized, and information profile can be built up about the particular individual based on their answers. So here's a typical example of a Clevertile product, and we're talking in this screen about goal setting, and you can see the sort of attempt to make a supportive conversation and then to extract some response from the user. Tell me what your goal is. I want to be able to run again. And then the conversation might proceed along motivational interviewing lines by asking the person to focus in on that goal and set some criteria. And then it might give a range of choices if it wants to customize or cater for the patient, the subject's preferences. So that's just a snippet. I'm going to hand on to Trish for her 2 projects.
So under the banner of infrastructure in a very, very general sense, one of the things that I was asked to do was to look at how you benchmark digital hospital infrastructure in relation to, information capabilities. And we tend to get quite hung up on technology at times. And as it says here, data and applications do not provide care, people provide care. And so one of our goals is to try and articulate that. But what we're doing is seeing what information systems can support that optimal delivery of care. And to that end, I'm working closely with the Cisco technology and architects, an infrastructure maturity assessment model was built, and it aligns the capabilities or it assesses the capabilities of a digital hospital against what its business objectives are in 5 different areas, as you can see on that diagram: transport, mobility, collaboration, security, and data. And what it does is it produces an ability for an organisation to know where they are, but then based on what they think they would like to be able to do, how do they get there? What incremental steps can they take to actually achieve those objectives? And this has been something that has been quite successful for Cisco themselves in supporting hospitals, but also was adopted by HIMSS as the new international benchmark for being able to measure infrastructure in hospitals, and goes alongside, some of you may know about MRAM, which looks at the maturity of electronic medical records in hospitals, and this one goes alongside that and is called INFRAM. And part of that, or a side part of that, in fact, was looking at clinical incidents that related to technology, but particularly to wireless and wireless failures. So we undertook a piece of work alongside the original one that allowed us to create a model where Cisco can train their installation partners, as well as the hospitals be much more aware of what they should be looking at and all of the pitfalls, in fact, of putting in wireless. Unfortunately, the issues that you get from a clinical perspective that relate to wireless are not very well understood. And in fact, there was a whole range of issues from, the defining of requirements back down to, configuration and even retirement of equipment that was causing these problems. And the other section to this that relates to digital infrastructure is we spend a lot of time looking at patient experience and defining what a good experience would be, or how do you improve people's health using Antonovsky's salutogenesis theory, which is all about a sense of coherence. And those of you who work in the wellness area will already know about that. And we undertook some work with Fiona Stanley Hospital in Perth, looking at how do you improve their ERAS project, their ERAS process, because a lot of care is not just within the hospital, but it's actually either end of that hospital admission. And so at the moment we are about to produce a couple of papers around how you link patient experience to that digital infrastructure. And you can see on here that a lot of it is around what happens rather than the technology itself. It's about how can the infrastructure support where you need to have teaming, where you need to have coordination. There is always an education element in there, and what part does monitoring play? And it's a really interesting exercise for hospitals to be able to see that they can improve their experience, both for the patients and the clinicians, quite quickly by realizing that most of the time they already have a lot of these capabilities. They just don't integrate them well into workflow, or in fact, they don't even realize that they have them. And the other major project that we're currently working in, as I said, brought to a fruition mainly because of COVID becoming quicker, is the fact that we have, during the COVID pandemic, adopted more telehealth, and more widely, although, you know, telehealth has been with us for quite some time. But we needed to move away, I think we need to move away from just telehealth to looking at that broader concept of virtual care, and what does that mean? What are we trying to solve by doing that? And it is very much about care that's centered on the needs of the patient, and being able to deliver that care where and when it is needed rather than where it's available. Obviously, we've seen in COVID that if you can't physically go to somewhere, then you need to be able to provide care in a different way. And I think it gives us the opportunity to be able to change how we deliver care. And, but I think it will be quite a long journey in being able to do that. And so the infrastructure, and I term this as an infrastructure quite broadly, that needs to support that. You know, you need to have that integration and between people, infrastructure, policy, processes and information. And what does that mean? What, you know, we need interfaces, we need integration, we need interoperability, and in some cases we need international standards for all of those. So this is about trying to define what virtual care actually is, and what are all of the components that need to be addressed or start to be looked at. And it's obviously a very complicated sphere to start working in, but I don't think that we need to go away from that or be detracted from it just because it's difficult. It's much more about how do you coordinate all of these things. And we've done a number of case studies, but one that I think is really important in using like a virtual care environment and technology enabled was that Wollongong Hospital ICU has expanded its bed capacity during the, you know, to cope with COVID. But the ICU were very concerned about the fact that, you know, you're isolating patients, even if they're not in ICU, but families and loved ones feel very disconnected. So they came together with a company called Talika and Cisco and another company that does a lot of security sorts of things called Citrus, and developed a solution called How Are You? And what it does is it allows the patients to be connected to their family very easily. So this is not, one of the problems when we talk about that connection is, well, why don't we just use WhatsApp, or we could use a Zoom or whatever, but that requires interaction and setup and scheduling. But this solution doesn't need that. Once there's a one click for the staff nurse to be able to actually set it up in the first place. And then it's there, it's persistent and it's secure, and it's there for the patient and their family all of the time. And in fact, there has been a couple of cases, one in particular that I think is really important. And an older gentleman had COVID. His son lives in the UK, and they managed to have 2 very private 2-hour sessions together before, unfortunately, the gentleman died. But that was something that wouldn't have been able to happen had, you know, they just been looking at, you know, ordinary connection solutions.
So that covers the 4 projects, and I just have a last few slides which are essentially future reflection. I want to talk about some current initiatives that we've been involved in, because the centre's existence as a self-standing independent unit is not a feasible, sustainable model long term. We need to form scaffold with other entities. We need to get involved in projects that are beyond the scope of South Australia. And so we've been involved in the national discussions on artificial intelligence for health, which we're hoping will lead to some sort of national body. And we've been involved with data science discussions similarly in the aftermath of the Data Decisions CRC, which we were part of initially. In terms of industry collaboration, we have a project with the Digital Health CRC, and we have a number of industry members as a result of that project, and we're trying to form more links for larger scale projects such as CRC ones. And we've also been part of the aged care reform discussions that have been happening both with the Royal Commission and with COVID. And then we've become involved in this kind of industry-driven smart healthcare ambition of producing and deploying sensors, wearables, creating smart environments in your home or your office where health issues are part of the environment's interactions with you. So, you know, imagine an office which coaches you to stand up and walk around more often, for example. So those are sort of technology and collaborative directions we've been following. We've also got involved in a number of international projects recently. Flinders has a strong relationship with a university in Germany at Dresden, and we've been working with them on broadening the living lab approach to suit some of their age community work. We have a relationship with several universities in China, and one in particular has an interest in cardiovascular risk. So we've done some work on mathematical modeling for population studies. And then we've had a long-standing relationship in Finland with the CSIRO equivalent there called VTT, and they have a particular interest in mental health. So we've been working with them, sharing some of our apps work. So in the future, we think that probably our centre will need to focus a bit more on the health informatics core areas. We started off with this consumer and digital enabled living ethos, but in some sense we neglected the mainstream of health in doing that. And Trish's work has shown that there's just endless need for technical involvement in that area. So we expect to spend a lot more effort in standards and data and so on in the near future. We want to diversify our collaboration. So we're reaching out to other organisations such as Melbourne Uni to see where we can find overlaps and projects where our joint participation would add a lot of value. And we're doing that also with health services, of course. And then we really hope that the kinds of partnerships that are forming will allow us to share our expertise on many fronts. So education is a very good example of this. There's a very active dialogue about the future of the digital health educational agenda, including the workforce impacts in this country, and we'd be very glad to participate in that. And then forming other groups and relationships with national agencies, such as the Digital Health Agency, are on our agenda. So we're looking forward to another active 5 years. And at that point, I think I'll end the presentation and we can start to work through questions.
Thanks, Anthony. Thanks, Trish. Thanks for sharing about your incredible work and projects that you've amassed over the last 4 years. I know that both of you have to dash off to another speaking event, which begins at 1, so we'll aim to end today's seminar a little bit early. We have about 15 minutes for questions. I have the first one from Cecily. Would you be able to tell us a bit more about your involvement in aged care initiatives?
Yeah, a little. So I think there have been two major areas of involvement. The one has been what you saw with FAME, and we've done several other projects like this, where we're interacting directly with the subjects of care and trying to provide them with IT tools which they find useful. So the survey project that I mentioned briefly as an example of this, we found that people, for example, wanting to increase their level of physical activity need incentivization to do that. And one way of providing that is some daily check-in on a tablet. And it can provide motivational messages and keep track of their activity. At the other end of the scale, we've been working with the aged care organisations to try and provide them with IT tools that let them run their organisations a little bit more comprehensively. So, for example, we've produced a dashboard type system which allows end-of-life care planning, which is actually quite a complicated task with many roles provided by many different individuals. So being able to coordinate that and provide reports on progression over, say, the last year of life has been very useful to care providers.
Thanks, Anthony. I have a question from Mike South. Can you comment on the sustainability of funding for your centre?
We'll take as much as we can get. The university underwrote us to the extent of startup, and I think, you know, they clearly would continue to support academic positions, but funding for postdocs, funding for projects is something we've had to approach through the normal competitive grant scheme and contract opportunities. So at any one time, we've usually got 4 or 5 major grant applications in play. And, you know, with a normal success rate of 5 to 10%, you're really only going to get one of those a year if you're lucky. So the advantage of being multidisciplinary is that that can happen simultaneously across different colleges. And we've had very good experience with different members of the centre being willing to take the lead on running with those kinds of proposals. So I hate to say this, but we're probably going to be sustainable because we put in so many grant proposals that some of them have to come off, rather than that we have a very focused, very targeted, very mainstream source of funding. And that means we have to pivot on a shorter time frame than most centres. We're probably going to have to reassess priorities every 2 or 3 years rather than on a 5-year cycle, I would say.
We have next question from Sam. Do you have any experiences of the transfer of data that's Sam? Correct me if I've got your question wrong. So transfer data that's poorly applied with semantic meaning, which affect the quality of care. In other words, beyond physical endurance, how do you ensure consistency and quality of transmitted care data?
Yeah, that's my question. Thanks, Dr. Chu. Yeah.
Sorry, so the question is, have we been looking at data with semantic meaning as well and context?
Yes, since I know that for some of the standards or the episodes you are looking for, it's having some data quality issues, and if you transfer them, they still have data quality issues. So how do you view this impact the quality of care? Thanks.
In terms of, well, I think in terms of the quality of care, I think the way that we look at it, we're not suggesting new clinical pathways, you know, in any way. So looking at things that go into workflow don't necessarily rely on that quality of that data. If you're looking at things like changing care processes, then absolutely that quality of data is important. And I think it depends on how you're actually getting that data. So we're not, you know, and I don't know about this is in the AI area, Anthony, but, you know, for the majority of the work that I do in looking at how do you improve processes or how do you improve delivery of care through information systems is partly, you know, improving the quality of the data itself rather than being a receiver of it is part of that. And we've also, you know, I have a student at the moment who's looking at failures in information flow, which again includes quality, but also a lot about that communications and how you do it. And that it's that sort of side of the data that we're looking at rather than the actual quality of the clinical data.
Okay, thanks, Trish. Yeah.
Thanks, Trish. I have a question from Kathleen. Can you comment on workforce capacity and professional development issues or activities that impinge on implementation or scaling up your innovations?
That's a good question, Kathleen. I think what we're finding more and more is that there is a really strong need for additional education and maybe skills development in a lot of the areas, in the fact that whilst we're quite familiar with technology, and you know, we tend to assume that because technology is everywhere, everybody is familiar with it. But where you are trying to do that in your work environment, in healthcare particularly, it is actually quite difficult. And in particular, when we start talking about telehealth and virtual care, I think there's a whole upskilling part of even the medical profession that needs to happen to be able to engage properly in the use of those technologies. Because medicine is a very hands-on profession. So when you start to move that to a more virtual environment, or even just including other sorts of technologies in it, there is quite a learning curve for all clinicians to be able to take that on board. So I think there's quite a gap there still, Kathleen.
Thanks, Trish. The next question is from Peter. So regarding the virtual care case study, can you comment on the balance between digital health ethics and the need to possibly switch on monitoring gadgets for relatives in ICU without their consent? For instance, during physical care by a relative, no permissions are required, but to remotely monitor a patient in ICU, that there might be a need to switch on the monitoring system if the patient in the ICU seems to not be responding to requests from their relatives at home.
What actually happens in that particular case in ICU, because this thing was actually the case study I was talking about, that example, was designed so that in fact the family can leave messages and images and voice notes, etc., whilst the patient is unconscious. So that when the patient becomes conscious again, they can actually, because it's a persistent space, can then actually see those, and there is some evidence that it actually helps their recovery and having that contact. And the monitoring, so that particular system doesn't require intervention from anyone else for the family to be able to do that. Obviously, if there is something else going on with the patient, then the video for that still needs to be initiated, you know, by one tap for that to happen. But the other thing that's happened is that it's allowed family members to be involved in difficult clinical decisions with the patient who, you know, is in a compromised state anyway in ICU, and in consultation with the physicians who are there. So that's actually been quite useful.
Thanks. The next question is from Warwick. What are your plans for your international project with Shandong on the CV risk prediction? And do you have practical translation or implementation plans?
The difficulty with cardiovascular risk prediction is how to stratify. So the risk predictors are fairly crude and based on models which were developed on a very linear regression type of basis many years ago in the US. And they rely generally on only a few factors. So we've been looking at three different things. Can we increase the number of factors and get better prediction? Can we stratify the type of cohort that we're trying to predict for? So, you know, people who have chronic disease or people who are later in life might have different risk profiles. And thirdly, can we provide a more comprehensive, refreshing or let's say, enhancement of models by using more recent techniques such as machine learning to adapt the model over time, rather than have a static model which might be based on 30-year-old data.
All right, thanks, Anthony. I think we have time for maybe one or two more questions. Does anyone have any more thoughts or comments?
I don't.
Hi.
Sumit here. Hello there. I'm just going to start my video if I can successfully. Sorry, my name is Sumit, and I'm the IDD lead for home-based care projects at the Alfred Health. Just quite interested in great demo. Quite interested on the dementia patients as well, because as part of one of our project, we are looking at enrolling some of the patients with dementia and musculoskeletal conditions, where not necessarily they're chronic patients. They're not long-term patients. They're only going to be recruited maybe for 2 to 3 weeks under the program, but really keen to understand how this program of yours or the project is helping those dementia patients as well.
Well, our program wasn't actually specifically targeting mainstream dementia patients, which, you know, as you point out, is quite a difficult group to work with. We're very much more interested in independent living than we are in the sort of deep care end of the spectrum. And so we're really concerned mostly with early stage, very early stage dementia, first signs of dementia, perhaps some sort of mild cognitive impairment, but not particularly people who are needing dementia care per se. And the idea is if you can intervene early enough and appropriately enough and give the person some level of self-help or self-management of their, you know, very at that stage minor condition, then perhaps you can slow down the progress of it, or at least you can enable the person to manage and understand and cope better at that stage before mainstream care is actually needed.
Thank you. And in terms of early interventions, are there any technologies that you foresee already available which will help and assist these patients as well?
Well, we went for the tablet because it's very portable, but I think, you know, clearly our main interest would be in creating a dementia-friendly home or a cognitive loss-friendly home in terms of the smart home model, because we think a lot more value can be gained by understanding the context, understanding the environment, having a kind of an ambient presence of the technology, rather than just a single shot technology like a tablet or a wearable.
Thank you.
All right. So
Time to say goodbye, isn't it?
So Anthony, looks like you have a quick 5 to 8 minute break between before your next speaking event.
That would be good.
Thank you very much again for your time today and for presenting to us about. We wish you continued successes in your projects.
Thank you very much. I'd like to have so many of you attend our session. I'm very impressed by the number. So goodbye from both of us.
Have a good afternoon, everyone.
Thank you.